Thanks, Greg, for that kind introduction, and it's my pleasure to be here, and certainly an honour to give the opening address at this very important meeting, and as Greg's mentioned, the first focused right ventricular structure and function day possibly in the world. So I'm going to go through some quantitation measures for right ventricular function, both systolic and diastolic. We'll review the transition from taking a look to actually measuring, and what does it actually mean? How can we use the information to improve patient outcomes? So I like to start with this slide because this tells a big story. When you're sitting down at Sydney Harbour and you're looking out at the harbour and you see this lovely big cruise ship, that's what your eye is drawn to. And I like to use the analogy as the left ventricle. You put the probe on the chest, that's all you see, is the left ventricle. And this little guy down the bottom here, the tugboat, who actually does all the work, is very little recognised, but he's always there and he's always working hard, and without it, the ship cannot get out of the harbour. So that's where I'd like you to focus your attention on the right ventricle and how important it really is to left ventricular function and outcomes in patients. The right ventricle is implicated in patients with heart failure, and as you can see here on the orange line, the patients with a reduced right ventricular ejection fraction actually do much more poorly if they have left ventricular failure. So it affects survival in these patients. What about dilated cardiomyopathy and heart failure? You can see that on the pink line, the high pulmonary artery pressures and low right ventricular ejection fraction have the worst prognosis of all in patients with dilated cardiomyopathy. And even if you look at the green and the yellow line, having a low right ventricular ejection fraction, it has the same mortality effect as having just a high right-sided pulmonary pressure. What's the prevalence of right ventricular systolic dysfunction in left ventricular heart failure? And you can see that even in patients who have an ejection fraction of the left ventricle of greater than 50%, approximately according to which measure you use, anywhere between 20 and 40% will have right ventricular systolic dysfunction, and as your left ventricular function gets worse, so too does the prevalence of right ventricular systolic dysfunction. What about right ventricular diastolic dysfunction? Here's a concept, and we'll go through this later. But again, if we're measuring right ventricular diastolic dysfunction in patients with left ventricular ejection fractions of greater than 50%, 30% will have right ventricular diastolic dysfunction. So how do we measure that? We'll talk about that later. So why is the right ventricle so special? It's structurally very different to the left ventricle, and we'll go through the muscle fibre orientation, but essentially it's got a large inlet, it's got a tunnelled outlet, and it has an basically has a separation of the inflow and the outflow, unlike the left ventricular inflow and outflow. If we look at the fibre arrangement of the left ventricle, you can see that the inner layer provides torsion and twist in a right-handed helical direction, and the outer layer provides the left-handed torsion or twist, which gives the left ventricle its ringing action. If we look at the right ventricle, however, you can see that the external fibres, or the epicardial fibres, actually wrap around in the same direction as the AV groove, and this gives it its circumferential function, and on the inner layer, the longitudinal fibres. So in terms of the way it pumps, it looks more like a bellows than a ringing motion. So it's low pressure and it's high volume. So we have the inlet, which involves the tricuspid valve, the chordae tendineae and the papillary muscles, the ventriculo-infundibular fold that separates the tricuspid valve and the pulmonary valve, and in contrast, this is in distinct contrast to the aortic and mitral valve fibrous continuity, the infundibulum or the conus and the smooth outflow region, and also the trabeculated apical myocardium, and of course the moderator band, which actually determines which chamber is actually the right ventricle. Because of these anatomic features, it does not allow us to provide any predictive mathematical model to the right ventricle because of its shape and the way it fills and empties. It does not allow us to apply these predictive models and mathematical models that we use for the left ventricle. The definition of the RV endocardium is difficult because of heavy trabeculations, and there's marked load dependence and very dramatic changes with respiration, unlike the left ventricle, which provide us with some challenges with measuring function. But as per the big boat on the harbour, the right ventricle is always on view. Pretty much any probe position that you use with an echocardiogram, you can see the right ventricle. But we always look at the left ventricle. So let's take a look. The parasternal long axis, the four chambers, the subcostal, and even the inflow view where you can still see a little bit of the left ventricle. The right ventricle is always on view. And so there's something there to be had and to be measured. In the short axis view, we can see all portions of the right ventricle. So while we might be looking at the left ventricle predominantly, we can certainly see the right ventricle and make some assessment of it. So what about the segmental anatomy and the systolic function? On each of these views, which most of you will recognise, we can see in these three views we get the lateral RV free wall, the inferior RV wall on these views, the anterior RVOT wall in these views, and the anterior RV wall in this view. What about the coronary artery distribution? We know a lot about the right ventricular anatomy and where the blood supply is coming from. And you can see that all of the right coronary distributions in the green, pink and red are represented quite readily in most of the views that we see. And also the LAD territory, which specifically affects the moderated band function, can be seen in the 5-chamber view. Now in the past we've used MRI as the gold standard, and obviously this has very high reproducibility and the image quality is second to none. However, it's very time consuming, it's not widely available to most patients, and certainly for serial measurement of function improvement or deterioration it's very difficult to come by, and a lot of patients can't have an MRI for various reasons. So while MRI is the gold standard, we like to think of echocardiography as the principal clinical tool to evaluate the right ventricular structure and function. As we know, it's a harmless energy source, unparalleled temporal resolution, very accessible to most patients and most hospitals and facilities, and relatively low cost compared to MRI. I think we'll hear a little bit more about MRI later in the morning and how good it really is, and I'm not turning it down too much. But echo is our workhorse, and this is what we need to use to actually assess the right ventricle on a serial basis. So where did it all start? In 2005, we had the members of the Chamber Quantification Writing Group, headed up by our colleague Roberto Lang. And in this document, there's a lot of attention paid to the left ventricle, but not an awful lot to the right ventricle. And as you can see here, that while accurate assessment of RV morphology and function requires integration of multiple views, you can see that the structure and function remains mostly qualitative in this document. So this is 2005, and I'm pleased to say we've come a long way since then. Unfortunately, we had this paper published in 2007 which was comparing with MRI and basically told us that the 2D echo RV end diastolic volume correlated well with CMR, but the 2D echo right ventricular systolic volume, stroke volume, EF and CMR did not correlate with CMR at all. So it didn't really champion the cause very much. So what we were left with was, well, as Greg said, what does it look like? Does it look like it's working properly? Is it the right size? And that was really all the flyby comment that you got about the right ventricle in the past. Well, fortunately, things have evolved. So the questions that we should ask about the right ventricle is the structure, is it big or not? And how does that help us stratify patients for high-risk groups? And also the function of systology and diastology and whether these are normal or not, and how do they affect prognosis? So is it big or is it not big? That is the question. What about RV mass and free wall thickness? I mean, we all have a look at the RV free wall in these views, and some people like to measure it, and the guidelines even state that if it's less than 5 millimetres, it's probably a normal width. But we know that it's not really a reliable indicator of RV mass. And if you look at the RV thickness here in this series, this is dating back to 1983, the RV thickness correlates very poorly with a post-mortem RV mass. So these patients had an echo within 6 months of their death, and then they were taken for post-mortem evaluation of the RV, and you can see there's a very poor correlation between the RV free wall thickness and the RV mass. The sensitivity of the RV thickness greater than 5 millimetres was only 67%. What about in patients who have the RV wall thickness measured at post-mortem? The slide on your left shows that the RV wall thickness measured in millimetres of the free wall correlates again very poorly with the post-mortem RV mass. It's a bit more like a shrapnel rather than a straight line. And on the right, you can see that the RV wall thickness, if you measure it at 5 millimetres, as indicated by the horizontal bar, that the post-mortem RV mass is actually is very variable. So it's really not that reliable when we compare it for making an assessment about whether the RV is thick or not. So it's a poor indicator of RV mass, but you could consider the use of this in an individual patient as a parameter to follow over time, particularly in congenital heart disease, pulmonary hypertension or hypertrophic cardiomyopathy. So what about the volume? How big is it? How stretched is it? Does that help us? Again, if we look at the internal diameter on echocardiogram and compare it with the post-mortem RV mass, again there's a very poor correlation with how much muscle there is and how big the chamber is. And keeping in mind that when the right ventricle actually responds to pressure or volume overload, its natural hemodynamic response is to dilate. So you would assume that the bigger the ventricle, the bigger the RV mass, but that's not strictly true. We can measure the RVOT, we can measure the internal wall at the base and the mid and the apex, and there are lots of guidelines as to what these measures should be, and they still exist in the guidelines. But again, these don't actually help us in terms of mortality or predicting morbidity events. And these are the recommendations in the 2015, which you can find on the American Society of Echo website. So where did we go to from there? 2010. There was actually a specific right ventricular assessment paper which started to introduce some of the more practical and quantitative methods for looking at right ventricular function. And this has been serially followed by a quantitation paper that was published last year, which most of you will have updated your left ventricular indices, but I bet very few of you have updated your right ventricular ones. So we've dealt with the structure, big or not, doesn't matter. What about the function? This is what matters. This is what actually determines prognosis. So let's first of all deal with systolic function. And there are 5 key measurements that we can take, and they are listed here. And for each of these, there are normal ranges that are published in the guidelines. So let's first of all deal with TAPSE. TAPSE stands for Tricuspid Annular Plane Systolic Excursion. It measures longitudinal shortening, which is an easy way to assess and follow RV function, especially given that 80% of the cardiac output on the right side is determined by longitudinal function. It's a sensitive indicator of impaired function and can be reduced while the radial function is still normal or even compensatorily increased. And it's very often reduced after cardiac surgery. And we're actually going to hear a lot about some intraoperative right ventricular assessment later on this morning. So how do we measure it? We get an RV-focused view, and very often this means moving your probe in towards the centre of the chest to get the RV on a better view. We line up the motion of the annulus here with our cursor and make sure that the annulus is actually tracking along that cursor. And if you try this in your labs, if you're not already doing it, there is a wide variation as to how that annulus tracks, and often needs to be repeated to get an accurate measurement. You can put colour over there as well, and this actually helps you determine which is systole and which is diastole on the colour M mode. So you can see here if we measure TAPSE, we want to measure at the very nadir, and then we want to measure how far it comes in longitudinal shortening, and in this particular patient the TAPSE is 26 millimetres. What does it mean? Well, if your TAPSE is greater than 15 millimetres, there is a very good chance that you have normal RV ejection fraction. And as the TAPSE drops off, as elegantly demonstrated in this paper, the right ventricular ejection fraction drops off dramatically. This paper in 1984 actually compared ejection fraction by radionuclide imaging and also found that the 2D TAPSE of 15 correlates very well with an ejection fraction of 50%. In the guidelines they say 16 millimetres, and I'm not sure why they changed it because there's no new data to evaluate that. And this is actually looking at MRI values in patients who have ischemic heart disease, pulmonary hypertension and also normals. And you can see there again that the ejection fraction by MRI is very nicely predicted by the TAPSE of 15. What are the practical tips? You can use just simple M mode or overlay the colour M mode. That you need to align the annular motion, and you also need to note the depth of the annulus to avoid measurement error. So those markers down the side of your 2D image actually help you when you're measuring the systolic excursion. What about annular tissue Doppler? Let's have a look at that. So again, an RV focused view. We want the tricuspid annulus to be moving in the plane when you drop your cursor, and you want your sample volume to include the entire cycle of systole, so that when you're in full systole, the cursor has still moved through the entire annulus. And a lot of times I see the cursor being placed either too far out or too far in, so it's very important to line that up. Then you put your tissue Doppler overlay over that, drop the cursor again, make sure you're still in the right spot, and you should get a trace that looks a little something like this. So an S wave, which is the upward deflection, and the E and the A wave, which are the downward ones. What's normal tissue Doppler with age? Well, we know that the systolic velocity of the tissue Doppler with the right ventricular free wall doesn't really change that much with age. You can see over the age of 60, it's still about 15. And before 40, it's 15.5. So it doesn't really drop off in this as people get older. If we take away 2 standard deviations, the lower limit of what's considered to be normal is 11.5. And the guidelines actually have dropped it down to 10. Again, I'm not familiar with the data that has supported that because this is the best data available. Similarly, as we'll get onto later with the diastolic velocities, there's a little bit of drop off with age, but you can also see that if we want to look at the E prime and the A prime, we can do this. There are normal ranges for these measures. So this is what I teach as the normal values for tricuspid annular TDI, that the S prime should be 10 or more, the E prime should be 9 or greater, and the A prime 8 or greater. The other important thing about tissue Doppler is that it doesn't change with respiration, as does tricuspid inflow, which we'll talk about a bit later with diastolic assessment. It does not alter at all with what volume is going in or out of the right ventricle. So it's a very useful and reliable and repeatable measure for these purposes. The systolic peak velocity and the ejection fraction are also relatively well correlated, and that if your systolic velocity is less than 11.5, it can be used as a predictor of RV ejection fraction less than 45% by radionuclide ventriculogram with those sensitivities and specificities. So it's relatively simple and easy to measure. What are the tips? Align the annular motion in the 2D RV focus view, do the tissue Doppler overlay, and make sure your sample volume is correctly placed. Next is the right ventricular Tay index, or the Doppler-derived index of right ventricular myocardial performance. This is a useful measure looking at patients with primary pulmonary hypertension. They're usually much higher with their Tay index than a normal patient. And the Tay index in primary pulmonary hypertension survival drops off dramatically if your value is greater than 0.83. In chronic thromboembolic pulmonary hypertension and treatment with thromboendarterectomy, you can see that the Tay index drops off quite dramatically. Unfortunately, the RIMP is a combination of systole and diastole, and we have very good methods of measuring these separately, and lumping them in together like this isn't as accurate as we'd like to think. So the way we measure it is that we measure the tricuspid flow and compare it to the ejection time. And basically we're looking at the time spent in isovolumic contraction and relaxation states, and this can't be easily done with tricuspid inflow. So the normal value as published by the ASE is less than 0.43. 10 years ago it was 0.4. So how do we measure this? We take the RV inflow or the tricuspid regurgitant signal and we measure the duration of either tricuspid regurgitation or the end of inflow and the beginning of inflow, which is A, and we divide it by the RVOT, which is B, and we form a percentage, 0.25. Can also be, unfortunately with this one you need 2 cycles and they might be slightly different heart rates. So this is important if you're doing this measurement to make sure that you've got a solid heart rate and not much variation between these 2 captures. You can do it on the tissue Doppler, and this has a higher range because it's much more sensitive and accurate, and the normal range for this method, where you measure the same intervals essentially but with tissue Doppler, is less than 0.55. And these are the normal ranges for the RV IMP for babies, children and adults. What are the problems though? As I mentioned, systolic and diastolic function should and can be assessed separately. Pressure and volume can affect the TAE index quite dramatically. If you dry the patient out, miraculously the TAE index goes up, which normally would be a bad thing. So it's not always a reliable indicator of improvement with treatment. And it may include some pre-systolic time. You can get rid of that with the tissue Doppler method. So there's no real advantage in combining these measurements. Since the relationship between the systolic and diastolic function varies markedly, and again, combining them into one index reduces the usefulness of the measure. But if you don't have an RVSP and you don't have a mean pulmonary artery pressure, the RIMP may actually be used as a surrogate for significant pulmonary hypertension. So it does have its uses. It's just not very good at tracking treatment. The fractional area change is basically the surrogate for LV ejection fraction. It has established prognostic value and correlates well with CMR and reflects both longitudinal and radial components of RV function. Unfortunately, it neglects the RVOT contribution to systolic function, and there's poor inter-observer reliability for serial measures. And I'll show you why. When we do the short axis view and then translate that to a 4-chamber view, you can see that depending on where you slice that short axis view will determine which 4-chamber view you get. And the RV can look small or big depending on where you slice it. So if you slice it through here, you'll have a bigger measurement. If you slice it through here, a small one, and even smaller through here. And so getting the right axis for the measurement of ejection fraction is often very, very difficult. And certainly between measurements 6 months later, you don't know which slice you had to begin with. But let's take a look at how it's measured. If we have an RV focused view, we can take the systolic and diastolic area and track the endocardium as best we can. And in this particular example, the fractional area change is 60% and a normal value is greater than 35%. Now, what about RV strain? What about RV strain? This is a fairly new concept and over the last 5 years has really evolved and come of age, I think. There was this article in 2013 in Cert Cardiovascular Imaging which says, look, is it actually just the flavour of the day or does it have some value? And I think it really does have some value. It was brought about by this study which was performed at the Mayo Clinic. And this actually looked at right ventricular strain for prediction of survival in patients with pulmonary hypertension. And in this one here, symptom progression was worse if your free wall strain was less than 12.5. Your use of diuretics and edema despite diuretics was also worse if you had a free wall strain less than 12.5. And you can see on the mortality curve, over a follow-up of 4 years, you did much worse if your RV strain was impaired compared to someone whose RV was not impaired with pulmonary hypertension. They went on then to actually look at, well, let's look at all the people who were referred for a possibility of pulmonary hypertension. And they looked at 575 patients, again at Mayo Clinic, And what they found was that quantitative assessment of the RV free wall systolic strain is feasible and is a powerful predictor of the clinical outcome in patients with known or suspected pulmonary hypertension. So even the all-cause mortality, whether you had pulmonary hypertension or not, is basically if you had a TAPC of less than 15, your mortality, all-cause mortality in 18 months was 20%. And what about the time free of cardiac events or pulmonary hypertension medical intervention? Again, a TAPC of less than 15 increases your chances of having a worse outcome or morbidity events. So we can use this to look at disease progression, right heart failure, development of symptoms, and correlates very nicely with symptom development, and also has a predictive value for mortality. And this can be used for newly diagnosed patients and also those following treatment. What about those who are treated? 50 patients from this series, again Mayo Clinic, free wall strain in treated patients with primary grade 1, class 1 pulmonary hypertension. And in these 50 patients, pre and 6 months into their treatment, you can see that a TAPC of less than 12.5% at beginning or follow-up was associated with a worse prognosis over 4 years. And similarly, if you did not improve your RV strain by more than 5% during your course of treatment in that first 6 months, that also determined a very, very poor outcome. Whereas if your RV free wall strain gets better with treatment by 5%, you do much better. So this is an exceptional measure in this group of patients, which up until now we've had nothing. In AL amyloidosis, 52 biopsy-proven patients with 19 months of follow-up again showed that RV free wall predicted survival and mortality. And as we know, AL amyloid affects the LV first, but once the RV gets involved, things are going bad. And they showed that in this group of patients that RV free wall strain and BNP together were strong predictors of death, but that RV free wall strain was also a strong independent predictor. What about following myocardial infarction? This is a group of patients from our Italian colleagues, 621 patients at 2 years of follow-up, and the echo within 48 hours of admission. Now, didn't matter where the infarct was, what the severity of the LV function was, but what they found is that RV strain provided incremental independent value to clinical information, infarct characteristics, LV function, and fractional area change when looking at mortality over a 2-year follow-up. So this is an impressive measurement that I think when a patient has pathology, possibly should be included in their follow-up measurements. If you're going to put an LVAD in, who is going to do worse and need RV support and who's not? It's not cheap to put an RVAD in if someone needs it, but you don't put it in everybody. So this particular study at the Cleveland Clinic looked at 117 patients. 40% of them developed RV failure post-LVAD, and the free wall strain was significantly different in the patients who needed the RVAD support or more than 2 weeks of inotropic support. So less than 9% in these patients helped predict who needed right ventricular support when LVAD was being put in. And this fairly recent paper just published last month from our Italian colleagues looked at all of the different vendors and compared men and women. They also compared free wall strain with global RV strain. And you can see that when we separate out just the free wall segments, which I'll show you in a moment, that the overall values compared to global are higher because you take out the septum. And this is the one that's actually been used to follow all of these disease populations to look at mortality and improvement with treatment. You can also see that in women it's slightly higher than in men. So it's not the same for men and women together. So in these patients referred for heart transplantation, the RV longitudinal strain, surprise, surprise, is a stronger predictor of outcome than the LV longitudinal strain or other conventional parameters, and providing a stronger prognostic stratification as to who will do worse on the waiting list before they get their new heart. And that was just deemed to be negative 15%. So what are the technical considerations? We need an RV-focused view. Again, as for all the other measurements, it's angle independent. The frame rate should be greater than 50 frames per second. We can measure either free wall or global strain, but free wall seems to be more reliable. And we need a region of interest which is composed of 3 concentric lines with an endocardial, epicardial and mid-myocardial layer. So this is our RV focus view, and we place the cursors on the basal posterior free wall, the basal septum and in the apex. And then your vendor will actually usually automatically track, and you can modify this based on whether you think it's actually in the right place or not. And this is what it should look like. So you can see it tracking there, and you've got the 3 layers and they're all different colours, and that represents the 6 segments. So it will tell you whether it's tracked it properly in the 6 segments. What we do in our clinic is we take away the septum altogether, and that leaves you with the free wall strain. So this is the LV strain package applied to the RV free wall. And then you get a map that looks something like this. So you get half of the squash tennis ball here, and you get these lovely, hopefully overlapping free wall strain in the, somewhere up above the 20s. What are the advantages? Well, this is useful information in disease states and can predict outcomes. You can do it while you've got the patient on the bed, or you can take the pictures offline and do it later, and it's much less operator dependent. The pitfalls is that most people don't know how to do it. It's time consuming, or perceived to be time consuming, and it's not really part of routine clinical practice just yet. And the normal ranges, I think, are still being established, and as you see from all those disease populations, the cut-offs were very different based on what disease you had. So, do I have a minute to go through diastology? 1 minute. Okay, so diastolic function, this is something that really is in evolution, but there are normal ranges and things that we can measure. The right atrial pressure, as you know, is influenced and can be observed from each of these feeding vessels. But predominantly tricuspid inflow and tricuspid annular motion are the things that we want to measure. And if we can achieve an E over E prime, just like we do for the left ventricle, we can actually make some predictions about right atrial pressure. So, as we know, the left ventricular diastolic dysfunction has certain patterns that we look for, and similarly for the right ventricle, there are normal ranges that are published for these particular tricuspid inflows. Normal, delayed relaxation and restrictive, there's no pseudo-normal in this pattern. And the hepatic veins, as we know, change with increased right atrial pressure and RV compliance. But what we see with respiration can give us a great insight into what the RV relaxation properties are, what the compliance of the ventricle is like, and what the filling reserve is. If we look at normal, you can see that E prime and E is normal, and the deceleration time is normal, just for the LV. We take a breath, the flow should go up, and the A, so both the E and A should go up, and the decel time may be decreased a little bit. In delayed relaxation pattern, this is the start of the badness. If the E is less than the A and the E prime is less than the A prime, you'll see when you take a breath, you see what happens with reduced RV compliance. And that is you get a much bigger E wave, slightly bigger A wave, but the decel time doesn't really change. This is actually the reverse of pseudo-normal with Valsalva in the left ventricle. So this is useful information. It tells us that the compliance of the RV is not coping. And then we have reversible restrictive. Take a breath. The decel time gets shorter, but the E doesn't change, and you can see the E prime and the A prime are very, very low. And irreversible restrictive, nothing really changes, they're just breathless. So, what are the key measurements for this particular measurement? E over E prime we can use with tricuspid inflow without inspiration, tricuspid annular motion with an E prime, and just as an example, that's how we measure it. So in this patient it's normal. And I'll just skip through this, I think. An E over E prime ratio of greater than 6 is quite sensitive and specific for a mean right atrial pressure of greater than 10. So in my practice, what do? We do TAPSE, we do TDI on every single patient. And if there's free wall strain to be had, if there's a disease state, I think it's very worthwhile you measuring that as well, and it provides useful information and can provide regional information. I haven't gone into that today, I haven't had time. And in diastology, the tricuspid E inflow and the tricuspid annular motion to give you an E over E prime to look at what is the actual right atrial pressure. So in conclusion, ladies and gentlemen, the RV has many structural differences to the LV, and as a result, poorly appreciated and poorly understood, with the primary focus of cardiovascular function on the left ventricle. And we now know that the RV is an important prognostic indicator for many diseases, and that newer indices are providing insights into disease progression and management. RV dysfunction is common and is generally underreported. Systolic and diastolic function can be very easily measured, and most hemodynamic information is readily obtained. And visual RV function doesn't cut it anymore. You can't say it looks okay. Understanding the right ventricle lends great insight into the management and disease and patient prognosis. Thank you very much.
Well, that was an outstanding talk, and I think we're all just going to go back and now and change those reports we did yesterday that said the RV looks okay. Very comprehensive and diligent talk. So I'm now going to ask you to, if you have any questions, to put them onto the website while we're setting up here